So I would just like to welcome everyone to Impact Education's Payer Talk CE program entitled Health Plan Best Practices in Psoriasis, Overcoming Access Barriers to Advanced Treatments. My name is Jeff Dunn. I am the President and CEO of Cooperative Benefits Group, which is a transparent pass-through PBM located in Salt Lake City, Utah, and I will be moderating today's program. The program is jointly provided by Impact Education LLC and Partners for Advancing Clinical Education, and it is designed for one contact hour of continuing education credit. This activity is supported by an independent educational grant from Johnson & Johnson, and we would very much like to thank them for their support. At the conclusion of today's program, you will be able to complete an evaluation. This must be submitted in order for you to receive your CE credit. So you'll be able to click on a complete evaluation button in the navigation within the activity. And then once you complete your evaluation, you must then click Claim Credit to download your certificate. Or for pharmacists who are with us today, then you can do that to submit your credit to the CPE monitor. So I am joined today by Dr. Adam Friedman, who's a professor and chair of dermatology, associate residency program director, director of translational research, and director of supportive oncodermatology at George Washington School of Medicine and Health Sciences. And maybe a few other things, Dr. Friedman, you could be a director of down the road, fingers crossed. And also joined by Susan Westcott, who is the senior director of pharmacy and managed care at the Mayo Clinic. Welcome to both of you.
Thanks so much. I appreciate the volunteering to take more onto my plate.
Thanks, Jeff.
Yeah.
I'm excited to be here today to discuss this important topic. And this is a growing area of focus for payers, clinicians, and patients alike.
Absolutely. And it's complicated when we get into it on the managed care side with contracts and market baskets and everything else. And obviously, specialty is top of mind for employers and health plans. And so there's going to be a lot to talk about today. So I'm looking forward to it. Today's agenda will focus on psoriasis specifically, including the overall burden of disease, the additional burden posed by common comorbidities and patient history, an overview of new and emerging treatment options, how patient preferences influence treatment decisions, and approaches to improve timely and equitable access to evidence-based care. The learning objectives for today's program are highlighted here. At the end of the program, we should be able to identify how comorbidities, patient history, and patient preferences influence treatment decisions, analyze the role of newly approved and emerging psoriasis therapies in care planning across different disease severities, and finally, assess approaches to enhance timely, equitable access to evidence-based care for individuals living with this condition or this disease. So with that, I'm going to turn it over to Dr. Friedman. I just want to maybe launch it by asking you a question. What are the current and potentially unique challenges facing patients from an educational and care perspective?
I appreciate the question. I think maybe to start through a optimistic lens, taking a step back, because I think you are absolutely right. That question is just as valid as it is now as it was 15 years ago, pre many of the kind of unique therapies we have. Right now, it is an incredible time to be a psoriasis patient. We are at a time where national and national organizations are yelling from the hilltops, treat to clearance, that we have the ability to completely clear someone's visible disease, which in parallel, and we're getting more interesting data on this, will also impact the holistic consequences of untreated disease. So it is an incredible time. I like to tell patients that it's not about what do we do, but rather what do I choose? Because we have so many very safe, very effective options that really can redirect the trajectory of someone's chronic disease. And it's important to highlight this is a chronic disease we cannot cure, we can contain. But with all that positivity said and done, let's push that to the side. There are definitely still some challenges that really stem from many different gaps And you mentioned, I'm glad you mentioned education because there is both on the patient perspective, but also from the practitioner perspective, there are gaps in education that can impact diagnosis and getting someone on the right track. And then obviously education and understanding of the therapies we have. And I think that goes on the payer side as well in terms of the importance of treating this. I don't want to call it a skin disease. It's a systemic disease systemically to really prevent the well-described medical sequelae that can come. So let's kind of dive in a little bit by the numbers. And I'm always fascinated by how that percentage number has crept up over the years. When I was in my training, it was 2.2% of the US population, roughly the size of New York City, of individuals affected with some degree of psoriasis. I think it's important to take a step back and recognize where does this information come from? Well, it comes from big data sets. And actually, it originally came from calling people up and saying, asking them a whole bunch of different questions. Do you have this? Do you have that? And one of those things is, do you have psoriasis? Now, this goes to the educational piece that if you have a patient who has a skin finding and they don't know it's psoriasis, they think it's something else, well, they're not going to report that it's psoriasis. And I think that with the introduction of so many new therapies and public education campaigns and really a call from every organization in dermatology and beyond to really get these patients in to get them on the care that they deserve and need, I think people are doing a better job recognizing this condition, but there's still some work to do, and I'll explain why. But it's amazing that it's crept over. It's not that the incidence or prevalence has changed, it's that we're actually identifying these patients. A condition that historically was talked about, a condition that affected only those with lighter skin, absolutely not true whatsoever. And I would argue that some of these percentages, whether it be non-Hispanic Black or Hispanic, they're probably higher. We're just still, unfortunately, missing some of these patients. But something I think that is probably true, maybe a little underestimated, is that there is this love-hate relationship with psoriasis and obesity. Each is an independent risk factor for the other. And I think it boils down to chronic inflammation is bad for everything. And we're going to really lean in hard with respect to the concept of chronic inflammation is bad for every organ system, which is why probably every comorbidity you can imagine is associated with psoriasis. It's not that this isn't true for other chronic inflammatory skin diseases. I think psoriasis has become the poster child for this and has actually been the kind of call to action to evaluate this in other diseases as well. So, and speaking of some of those gaps, I really wanted to highlight the incredible diversity and the beauty of that diversity of how a skin disease, even something common like psoriasis, now we're saying affects up to 3% of the US population, how it can look different depending on where it is on the body, skin tone, how long it's been there. All of these patients have psoriasis. But to the untrained eye, it looks like these are multiple different skin conditions. And the issue is if you, during your training, are not exposed to a diverse patient population, if our textbooks and resources do not cover the gamut of the clinical spectrum, then you may miss the mark as the expert. But you can imagine, and honestly, everyone admits to themselves they've done this, that if you're wondering about a skin condition, what do? You go to Google image. Maybe now it's ChatGPT, and you'll ask, show me images of psoriasis. And if the resources available only show it in maybe individuals who look like the upper left, someone who doesn't look like that is not going to see themselves. And there's plenty of data to show that it takes probably 15 to 20 images deep to actually see darker skin tones. And so I think that there are gaps in the educational resources for our trainees, for our colleagues, but even for patients that may misdirect the diagnosis and then they go down the wrong path when it comes to managing a skin problem. But as I mentioned, this is not just a skin problem, this is a systemic condition. So out of the gate, let's come out strong. Head to head, a patient with psoriasis versus someone who doesn't have psoriasis, there is a overall increase of mortality. Forgetting to get into the details and the weeds here, that if you have psoriasis, there is a greater risk for an earlier death than someone without. And I think, and this is to thank, of course, industry's interest with FDA approved targeted therapies also came along registries and registry data. And so for years now, we've been collecting data on patients with psoriasis, whether they're on a medication or not, to understand in part the safety of those medications long term, but also what is just the experience of a patient with psoriasis. And I like to tell patients when they push back and say, "Oh, I don't want to be guinea pig. I don't want to try this. I'm afraid of the side effects." What is the side effect of not treating? Well, it's right here. The side effect of not treating is probably even worse than what's right here because this is an all-comer, is that you have a higher risk for earlier death than someone without psoriasis. And again, it boils down to chronic inflammation. Let's get a little bit more into the weeds, and this is still the outer crust of the pie. Pick a disease. I'll name a problem when it comes to psoriasis. When we think about patients with psoriatic disease, they are at greater risk for cardiovascular disease. I mentioned obesity already, depression, and this is not just because you have a visible skin disease. Yes, you can imagine the psychosocial impact of a condition you wear on the outside, but from a biological perspective, we know that the inflammatory mediators of psoriasis cross the blood-brain barrier. It directly affects mentation. It directly affects your psychosocial well-being. So it's not just simply, hey, I have a skin rash that doesn't go away. I'm upset about this. There's a biological basis for that as well. So these are just a few examples of that. And I like how it's in parallel to, okay, we have a patient with a dermatologic disease that is at higher risk and possibly has many comorbidities. How does that translate to healthcare utilization? And so what you're seeing here on the right is twofold: the number of the number of ambulatory visits and also pharmacy visits. And it is not surprising at all to me that these patients utilize our healthcare resources across the board more so than someone without psoriasis. One could argue that's probably true of a lot of chronic diseases, and I sadly feel that skin disease is often underestimated because it's topical, but it absolutely is not. But when thinking about this as a skin sign of systemic disease, this makes sense. These patients have multiple medical problems. And so when untreated or undertreated, these patients tend to use the healthcare services much more than someone without psoriasis. So there are a lot of things I think that really can be impacted by psoriasis. Certainly the skin symptoms, the appearance of the disease. Something I'll say is often in the real world out there, if someone sees a person on a bus or on a subway and they have a red or pink or purple flaky rash and they're maybe scratching or rubbing at it, the inclination is to think this is contagious, this is infectious, and so they back away. So I think skin diseases come with a very unique burden based on the visibility of it. There's an ostracism that comes along with visible disease, and so the severity of that will play a role. The location, if it's an area that you can't really cover up. But we also have to think about not necessarily lack of effective treatments, but lack of the utilization of effective treatments. I think that's more the issue. We still have an epidemic of under treatment, even though we have so many advanced and FDA approved therapies. But based on just the limited amount of things I've mentioned, you can imagine how psoriasis or undertreated can have a huge impact on someone's quality of life.
Awesome. Thank you. I want to interrupt really quick and ask for Susan's perspective on this. So I think we probably all know people who have psoriasis, if let alone probably some of us have psoriasis. Has a major impact on burden of life. Severe itch can be terrible, as just one factor of this. So I'm curious from a payer perspective, Susan, what's your reaction to this, whether it's from a prevalence perspective or incidence perspective, or even a burden of disease perspective?
Sure. So I think from the payer's perspective, Dr. Friedman shared that psoriasis is a relatively frequent condition affecting 3% of the US population. We know that obesity rates are increasing in the United States and expected to surpass 50% of the population by 2030. So that obesity being an independent risk factor for psoriasis and vice versa is also impactful to this population size. And we're also seeing that older age, over 60, we have an aging population right now. So many of us are going to age into retirement and the baby boomer population. And this means increasing incidence and prevalence over time. And that all creates a greater financial and care burden on the system. So we need more physicians and caregivers out there, and we need to pay for those people. And lastly, the fact that individuals with psoriatic disease are at a greater risk of developing cardiovascular health, MS, depression, and diabetes means increased spend and more care needed in those patients with a higher burden of disease. I'm also concerned about the decreased mortality. I think that's pretty shocking evidence, and that we don't see that tail end going up over 100 years of age, and the mean is 6 years earlier mortality in these patients. So I think that's very important from a quality of life perspective, Jeff.
Yeah, I think, Susan, you're picking up what I'm putting down in the sense that is more expensive to manage these comorbidities that come up over time than it is to get ahead of it. And we're seeing a lot of really even mechanistic data from clinical studies that these drugs can even in some cases reverse endothelial cell damage. These are the cells that line the inside of the blood vessels. Where on the flip side, when you don't have well-treated disease, and I'm reminded of a study from a while back that, and you mentioned cardiovascular disease, hypertension, high blood pressure, that it is much harder to get someone's high blood pressure under control when their psoriasis isn't under control than if it was. So I think you hit the nail on the head in that no question, a lot of these comorbid diseases that will come up, the longer this inflammation is let to run wild, they'll come up. That actually ends up being a greater cost to the healthcare system than if you got ahead of it.
I appreciate the comments, and I agree, Susan, that mortality data was super interesting to me. We have heard a lot about comorbidities over the last little while, specifically cardiovascular disease. And obviously, as you know, you've explained this, the inflammatory link and everything between these disease states makes sense. Um, do we know that by treating psoriasis, though, that we're going to impact these other outcomes? Is that too naive of a question? And then I'll just turn it over to you, and maybe you can dive into a little bit more on, what comorbidities we're talking about here and how you factor those into treatment decisions.
Yeah. Yeah. So the short answer is we do have some data to support
Okay.
that. The tough part is that, and we'll kind of think about it and kind of hypothesize, all right, what is the right medicine, given we have so many, for not just the right psoriasis patient, but the right psoriasis patient with the plus, 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 with the other stuff. But there is data specific to certain medications looking at the reversal that I mentioned, endothelial damage, the severity of other cardiovascular risk factors. There's been really great work over the years, but these are more investigator-initiated studies. Some of them were supported and pushed forward by some of our industry partners. But it does look like that if you treat psoriasis, if you inhibit or go after the inflammation that drives disease, it can have a positive effect on these comorbid diseases as well. So I think we're at a place where we can say, yes, it does. The question now is, well, which one is better for which?
Yeah.
And how do we kind of work that into the algorithm? Because we always have to be careful because obviously none of these medications are approved to treat those comorbidities to some degree. Psoriatic arthritis is a comorbidity, and so some are. Some are also approved for inflammatory bowel disease, which we'll talk about in a moment, which also makes that decision helpful because that is a comorbid disease of psoriasis as well. So we'll see some of that overlap. So yeah, I think the laundry list here is quite long. I tell patients that name a condition, it probably can be linked to psoriasis, from migraines to erectile dysfunction, and so this is probably the short list of conditions that directly have inflammation as their as their leading star. Others that result from chronic inflammation, but yeah, the relative risk for so many different conditions is certainly higher than the general population. We think that there is a correlation between the severity of psoriasis and some of these, but that doesn't always match up. And I think it's important to recognize that even if someone has 1% body surface area, so they have mild clinical skin disease, they still could have psoriatic arthritis. They could actually have psoriatic arthritis without any psoriasis whatsoever. So it's not necessarily a one-to-one in terms of, are we just seeing the tip of the iceberg and there could be significant systemic inflammation that's driving some of these comorbid diseases. So I think that's something to consider, that mild psoriasis doesn't mean a milder risk for some of these comorbid diseases. So this very complicated slide takes a really good stab at trying to think about the classes of biologics, one class or one kind of bucket of advanced systemic. So you have your biologics, which mean that these are monoclonal antibodies. These are proteins designed to target a signal that's being made in excess in psoriasis or the receiver for said signal. What's not listed here, but we'll talk about, there are also what are called small molecule inhibitors. As the name infers, they are teeny tiny, and they are designed to inhibit a protein machinery, usually inside the cell. So these medications, they're big on the scale of things, and from a cellular scale of things, they work outside of the immune cells, where small molecule inhibitors, oral medications work inside the cell for the most part. That is changing a little bit. And so you're seeing some of these comorbid diseases and classes of medications. The acronyms you're seeing here are related to the actual names of the generic names of some of these medications. There are kind of four broad classes. There's a little overlap between two, but you have your TNF inhibitors, which are historic medications, for which we do have now biosimilars as well. We did just see our first IL-12 and 23 biosimilar come out for ustekinumab. And then the later, I guess the more recent, I don't want to call them the new kids to the block, because they're certainly not at this point, but your IL-17 and IL-23 inhibitors, of which we have several, and they either go after the signal or in some cases may even go after the receiver, for example, for IL-17. Why it's not listed for all of these is that, for example, for inflammatory bowel disease, there is some concern, but it is somewhat unfounded, that IL-17 inhibitors might actually exacerbate inflammatory bowel disease. So we try to avoid using in that setting. And it's always nice to kill two birds, or kill two birds with one stone, I think is the old one. I think it's feed two birds with one scone is probably the more piece. I see Susan's nodding her head. I think that, kind of doubling down where some of these medications are approved for inflammatory bowel disease and psoriasis. So if you have a patient with both, or someone who might at risk for one and has the other, that might be part of the consideration. And then there's some contraindications when it comes to multiple sclerosis and TNF inhibitors that we have to think about as well, let alone pregnancy, where we technically have one that has it in the label, which is a pegylated TNF inhibitor that does not cross the placenta, and there are studies to show that. So I think that we're at a point where some of the patient features might lead us down one way or another, which allows for shared decision making and personalizing it. But we definitely still have some way to go. On the left, though, I wanted to include this because the GLP-1 agonists certainly have made a tremendous splash in the world of medicine, not just dermatology, but specific to derm and even specific to psoriasis. There is growing and rapidly growing evidence that these not only have a role in the obesity comorbidity, which obviously is very real, as we mentioned, but there may be an anti-inflammatory effect as well. These receptors are present on other cells. And actually, some of you may have seen, but there was a study recently combining an IL-17 inhibitor with a GLP-1 agonist, showing that the combination worked better together, which is a very exciting thing. And I feel like is now on the agenda of every dermatology conference. Everyone wants to talk about this, and rightfully so. So that's definitely going to change, I think, the landscape of how we think about therapy, that we're not just going after the clear target, but thinking about more global inflammation, how we can manipulate the various receivers in the body to get a better outcome. So certainly very exciting. So I'll turn back to you, Jeff, for some of the kind of discussion points related to kind of the goals when we think about psoriasis and those comorbidities.
Yeah, perfect. And yeah, I'll actually start with a question to you, Susan. What From a payer perspective, which of these comorbidities are relatively more important to a payer, maybe from a total cost of care perspective or even a quality metric perspective? And then how do you address it? How did this come up when you're talking about formularies and UM and policies?
Sure. So I think it can depend a little bit on whether the payer is government or commercial. The answer can vary, but some of these comorbid conditions sort of manifest themselves and have excessive expense over 65 and others under 65 on average. So when we see an over 65 population, that's going to be borne by all of us as taxpayers through Medicare. And if it's a commercial audience or ages sort of 18 years of age and up to 65, that's going to be on the employer side or labor side. So it's becoming more and more critical. We just talked about GLP-1s to manage metabolic syndrome, and it has this relationship with the inflammatory processes in all plan types. I kind of laugh that maybe everyone has to be on a GLP-1 at some point here for some reason. But in all plan types, we do care about this. And then secondly, mental health is also a focus for those younger populations and employer plans. So anything that activates the immune system or impacts day-to-day life are going to have definitely some focus from payers. I think the decisions that are influenced, to answer your question, by these psoriasis-associated comorbid conditions most closely align with disease and case management. So what do we do about it? We need to ensure that screening is done and that treatment is optimized. Cardiovascular risk and mental health treatments are cost effective, but they can't work if they're not prescribed and not monitored by ongoing care visits.
Perfect. Yeah, it to me, that is one of the biggest unmet needs. It's just more understanding from different stakeholders of these other pathways and comorbidities. And we're not just talking about skin disease. I think, unfortunately, maybe some people still look at this and say, hey, $50,000 to treat, something. I mean, that is, but it's way more than that. And that's what we're learning. And that but we definitely need some more information there. So Dr. Friedman, you've presented now some information on unmet need, comorbidities. What would you say are the most or the highest remaining unmet needs that we have in this area?
Yeah, I mean, I think the good news is we have great drugs and there are more coming. Selfishly, I would love to see some of these enter some areas that have no FDA approved medications. But I think one of the challenges and what I'm learning is it's not necessarily the safety of these medications that might, forget even scare off patients, but scare off practitioners. But it's actually the hurdles to get it approved for the patient. And so we often say the best medication is one you actually can get for a patient, and that's where I think some of these, whether it be prior authorizations, step edits, the paperwork required, depending on one's practice type and resources, that might be a deal breaker. And so I think that does contribute to the kind of pivoting and not treatment escalating, kind of adding to treatment inertia, that patients are being undertreated. I think it's better than it was. I mean, the earlier data from maybe 10 plus years ago was pretty alarming that a very large percentage of dermatologists did not treat patients with these, whether it be oral small molecules or biologics. But I think some of the access hurdles come from the amount of work needed to actually get approval for the medication. So I think, streamlined processes, making it a very clear approach. I think also it can erode the patient-practitioner relationship because, the patient is often told by the pharmacy, like, oh, we contacted your doctor, it's on them to figure this out. And the physician's like, well, I never got any message, and we fax something. We don't have a fax machine. Like, that's funny how that works. I think that these delays and this administrative work adds to burnout, but also adds to difficulty forging a long-term relationship, because that's what it is. This is a chronic disease, and so that certainly is important. So I think certainly finding more streamlined ways, or maybe even a shared language with respect to how we document and how the payers understand what we're saying, instead of us using validated research tools, which often we resort to, but also having more transparency on what the process looks like in order to maintain that good relationship. So I think that does. I mean, there's other things as well, but I think in the context of of this presentation, that certainly fits. But yeah, I mean, no doubt, well beyond that, I think the oral medication space has been present but limited. So actually, before we had biologics, our systemic agents that we utilize were oral immune suppressing agents. So cyclosporin, methotrexate, and they were better than nothing, but they came with a lot of baggage. Then entered these protein-based therapies, these monoclonal antibodies, which at the time were hitting heights that we never saw before. 75% improvement on PASI scores, which now is people kind of just like roll their eyes at now because we're used to 90% and 100% clearance. We saw the entrance of several oral medications that really did carry some nice safety. Efficacy-wise, was not the level of biologic, but definitely was better than a topical. So, some people refer to these as like gateway medications that could get people's feet wet with systemics. But I often felt that giving someone an oral was compromising efficacy for comfort or for ease or things like that. And so having an oral that matches an injectable, because these biologics, you can't, if you were to take them by mouth, in most cases, your stomach acid would digest them and wouldn't do anything. They have to be injected. To say to someone who only wanted to take a pill that, well, you have to sacrifice efficacy seems somewhat unfair. The good news is we do have a lot of great medications. Some work faster than others, unfortunately, and patients want to be better yesterday. And often it does take some time for those medications to kick in. And of course, why we're all here is to talk about access and cost. These are not cheap medications, but I would argue it is less expensive to get ahead of these comorbidities than to manage multiple comorbid diseases over time. So this seizure-inducing slide hitting on different pathways of the immune system probably overcomplicate things a little bit. And the pathophysiology story of psoriasis is really an incredible one. It actually highlights one of the kind of central tenets of science, which is the oops effect. The oops effect, and then, let's understand this. What I mean by this is our understanding of where we are now with the pathophysiology of psoriasis very much came from designing certain targeted therapies, not meant to target something else, but ended up doing so. And we learned that one arm of the immune system probably plays the major role. It's the lead antagonist, so to speak, which would be the Th17 pathway. But that was discovered kind of by accident, which I love that story. So much of science is by accident, making an observation and then going back and figuring it all out. So what you're seeing here is somewhat of a progression from left to right, where we thought that psoriasis was driven by type 1 inflammation. So this is, stimulation from IL-12 to naive sleeping T lymphocytes, polarizing them to this T1 pathway. And those cells then go on to create things like TNF-alpha, interferon, both in the skin, the joints, and elsewhere. But then we discovered that actually those same factors I mentioned are being produced by another pathway, which is the Th17 pathway right here in the middle. And so in a similar fashion to IL-12, IL-23 wakes up these sleeping lymphocytes in the lymph nodes, polarizes them to the 17 phenotype, and they go on to the skin and joints and secrete interleukin 17. And at the same time, there's some 22 cells as well. They play a role probably more in the thickening of the skin. But we now know, and it seems, so complex in this figure, it's actually pretty linear and pretty straightforward, that the majority of psoriasis patients are psoriasis patients because of an aberration of this Th17 pathway. And so the newer therapies that I've mentioned are really aimed at targeting, whether it be IL-23, that's the match, the thing that lights the fire in terms of waking up these naive lymphocytes and making them Th17 T members, or it's kind of like a sponge or the bucket that's taking in all the heat or all the water. By blocking IL-17 downstream, you kind of, in essence, achieve this same effect by targeting two different areas. And this is really where, right in the middle, that's really where we're focusing. Our focus is no longer on the type 1 pathway, but really more the type 17 pathway. And it is quite linear. So I think as opposed to many of the other diseases we manage, atopic dermatitis, hidradenitis suppurativa, chronic spontaneous urticaria, our understanding of the pathophysiology is pretty simple at this point, which is exciting because then we have ways to really go after disease and be able to say, we're going to get you clear, which is not easy to say for other diseases.
So this is interesting to me. On the payer side, Susan, jump in here if you have any comments on this as well. It's kind of a big market basket, and part of that is driven by the drugs and the pricing and contracting and how everything's kind of lumped in together. And I would say historically we don't make decisions by mechanism of action, but we have, as you pointed out, we have, IL-12, 23, 17, a bunch of other things. How do you use that to maybe choose which drug you're going to prescribe for a patient? Is that how do you match that up? Does that make sense? Yeah.
It absolutely
Yeah.
does, and I don't have a great answer. I mean, in my practice, I am predominantly using the 12s and the 17s and 23s. Actually, there was a study, head-to-head study comparing an IL-20, 12 and 23 inhibitor, so ustekinumab, versus just a 23 inhibitor, and the 23 inhibitor outmatched it. And so there's some belief that actually the IL-12 inhibition might actually undercut the IL-23 efficacy. So for me, I'm really focusing on those two. Now, how I choose is not necessarily so much a mechanism, though I will argue that when we think about, maybe I'll use an analogy of a leaky faucet. So you could either put a bucket and collect the water that's dripping. That's kind of the water is the IL-17 and the bucket is your IL-17 inhibitor. Or you could fix the sink in the first place and prevent the leaking. And that's stopping the activation of the leaky sink or the activation of these sleeping T cells by blocking 23. We find that blocking IL-17 does have a more rapid effect in some cases because you're just mopping up the mess, and so you have an immediate effect on inflammation. But from a sustainability effect in terms of, let's say someone's on medication, doing really well, and their prior authorization runs out, and they're off drug for a while. It seems to take longer for the disease to return because of the fact that you've been inhibiting the activation of those downstream cells. But really, it comes down to pragmatism. Does someone want a shot once a month, every 8 weeks, every 3 months? Is someone a world traveler that having a widely dosed medication would be easier for them? I think, also needle phobia is another one, infrequent for more frequent dosing. I think also it comes down to data. So if a drug has data showing me that it can reverse joint damage, the others might do it too, but they don't have the data. So I think it's a really great question, one that we struggle with, and we definitely don't have an answer to. But I think some of those kind of elements, especially the practical ones, are some of our guiding light.
Yeah, Susan, I don't know if you have anything, and it's okay if not. I'm just kind of curious, how route of administration or mechanism factors into your decision making, if at all.
Yeah, definitely. Those are typically the factors that drives drug selection in the office, I think. And as we look at comparative products in this market, it's getting to be a pretty crowded market, right? So big gains in safety and efficacy are always going to be important. We want to close gaps in care. We want to remember that we now have drugs that were breakthrough therapies available for 1/5, 1/6 of the cost through a biosimilar. And that gives us affordability for patients in a frontline treatment that may work for many, many patients. I think within the next 2 years, we're going to see generics for Apremilast and an oral therapy available for an affordable price. But with any of these new therapies, we also have to, there's always going to be, the nature of the drug manufacturers is they're going to promote their product. So we really have to ask ourselves in managed care, is this a game changer? Is this advantage worth this higher cost? That's the other thing I think about when I look at the problem.
Well, and to that point, that's where head-to-head studies I think are so important. And so when you think about it, so one with biosimilar, and I really highlight similar is not the same. And these drugs absolutely do not mirror the same efficacy consistently as to their parents, so to speak. But having in the phase 3 studies active comparators. The first to do it was guselkumab versus adalimumab. And we've seen this now time and again. There is a delta in terms of, the efficacy achieved from one over the other. So I think I don't want to say that older is always not as good, but in this case, without doubt, these newer therapies do confer a greater degree of efficacy than some of the more traditional therapies. And that goes to Jeff, your point about mechanism. Well, that's because they're addressing the actual newer age approach to the mechanism, and that we understand what's really driving disease versus kind of peripherally, which some of the older biologics really did so.
Perfect. I think that sets it up for where we want to go now, which is talking a little bit about the newer therapies. But really quick, there was an audience question, and rather than waiting, I just maybe we'll throw it in here
Yeah,
because
sure.
it's relevant. So it talks a little bit about maybe not everybody developing all of these comorbidities, but what is the role of the topicals? And then and I'll just augment this a little bit. When do you make the decision to move from a topical to a systemic, given the fact that they are considerably less expensive?
Yeah. So, I mean, I think topicals, well, one, topicals have their place in conjunction with systemic. So it's rare a patient is going to be just on a biologic. Now, after a certain point of being on it for a while or a small molecule inhibitor, and they're clear, the need for a topical kind of disappears. But out of the gate, they're getting both. I think for mild disease, where the mild disease is not affecting areas that are higher risk for some of these comorbid diseases, for example, scalp psoriasis, genital psoriasis, portend a threefold increased risk for psoriatic arthritis, and even a nail disease, double that. So I think that it depends on the patient. Are there patients with psoriasis who can get away with topicals? Absolutely. And some of these newer ones are very flexible, not being steroids that could be used not just an active treatment, but as a preventative in hotspots. But I think that in those cases, someone who is not responding, and we really only give them about 4 weeks or so, if they're not responding to a topical, it's not like it's going to start working 6 weeks, 8 weeks later. That would be a reason to maybe consider elevating to a systemic, whether it be an oral or injectable. Or if someone has mild skin disease, but they have signs of early psoriatic arthritis, stiffness at rest when that lasts for 30 to 45 minutes. Just because their skin burden's not high, if there's any evidence of psoriatic arthritis or early psoriatic arthritis, we may jump in. But yeah, there's definitely a cohort for whom topicals would be fine. But in the grand scheme of things, using a cream to treat a systemic disease, like saying use a cream to treat diabetes, it doesn't really address the systemic and underpinnings of the condition. But there are patients who have mild disease that really can get away with it.
Perfect. Thank you for answering that from the audience. And yeah, let's talk about the newer therapies, and then we'll probably move into pipeline.
Yeah. So I think that what's unique about this oral, and we're using it as an example, icotrokinra, while it's not the first oral therapy of late, it is unique in that's the first oral peptide-based therapy. And it's one that mirrors the efficacy of a biologic. So I was kind of setting the stage earlier that while we had orals, they were overall safe, effective, but not as effective as a biologic. So if you only want to go oral, then you have to compromise efficacy. No longer is that the case. And so this is a uniquely structured peptide that is a receptor blocker for IL-23. So as opposed to the biologics that go after the signal, this blocks the receiver for that signal that wakes up those T cells. And we see a very similar efficacy rate, or the percent of patients who are meeting a PASI 90. That means 90% improvement from baseline. And these baselines were moderate to severe. This is at the level of a biologic. So I think that's really the innovation. Some practical things, once a day dosing, I think makes life easier. It is hard to get patients to do things twice a day, whether it be apply something topical twice a day, take something oral twice a day. So I think that's also a nice, nuanced piece to this. But really, it's having an oral that mirrors the efficacy of a biologic, which then allows us to really enhance that patient decision making and tailor it to the patient. What you're seeing here is the head-to-head comparison, which is pretty common nowadays. Companies can't get away with, a monotherapy placebo-controlled study by itself, because we as the dermatologists want to see, all right, how does it match up to the gold standard? And currently, the gold standard oral is deucravacitinib, a relatively new TYK2 inhibitor. And we see a really nice separation very early on, as early as almost 8 weeks, in terms of efficacy rates compared to deucravacitinib. Pretty substantial up to week 24. Also looking at special sites. So I mentioned scalp disease. One, scalp disease portends a higher risk for psoriatic arthritis, but two, from a burden of disease perspective, quality of life, scalp psoriasis, though low body surface area, huge impact on quality of life. So we can't assume that small surface area doesn't translate into high burden, and there's been a lot of work to really harp on that. While it's great to have head-to-head studies, they're very expensive, and so we're not going to have head-to-head to everything. And so, how do we address this? Well, we use a research tool called the network meta-analysis. This does not have the same rigor as a true head-to-head, but it is a accepted in the scientific community approach to try to comparing studies to studies. So technically, you can't take two papers and say, in this paper, this drug 80% did better, and this paper 70% did better, so this is clearly better. It doesn't work that way. There is a way to kind of do that, and that's what a network meta-analysis does. And so what you're seeing here is the ranking of, efficacy, 90% improvement, safety compared to placebo across the spectrum of oral and systemic agents. And you can really see, especially some of the older stuff like methotrexate and Premolast, we're definitely seeing a breakaway from deucravacitinib. But what I really, and this came out before Icotrokinra came out, so that's why it's not included here. But it's just a nice way of kind of comparing efficacy to safety. And you can see on the right, most of these have really strong safety signals, but the efficacy certainly is variable. And then from a landscape perspective, we have many more things coming out, similar targets, but maybe some alterations in how they're delivered or bioavailability or impact on that target. But I think lower on the list is the approach of trying to generate a antibody or a small molecule inhibitor that has a long impact, meaning that maybe could you theoretically dose someone and give someone a hefty dose of a biologic once a year? That's really, that's kind of the goal. That's really what we're aiming for. That's the white whale of trying to minimize the dosing or limiting dosing altogether, but maintaining that high level of clearance. So there's still a lot to come, which is exciting, but certainly makes our jobs more challenging because then, Jeff, to your question, well, how do you choose when you have like 30 things to choose from? Certainly a good challenge to have, but one that is a little difficult.
Awesome. Really quick. So yeah, the FDA, I mean, their job is to determine if a drug works, not that it's necessarily better than something else. And they don't really talk about cost and all that. I get it, right? They have a job to do. So it's a bonus when we get head to head. We're not going to have that across the board. So yeah, Susan, from a payer perspective, how do you do those? So Dr. Friedman mentioned a meta-analysis, right? Again, that's on the, but in a practical like formulary world, how do you do the indirect comparisons?
Sure. So for my practice setting, which is at Mayo Clinic, we are a provider. We also have a health plan. So we're kind of looking across the whole spectrum of input. And it seems like step therapy is something that can be utilized here. We do this in collaboration with the experts. So they do have sort of complicated algorithms sometimes of when to use which therapies and when to go to a biologic or a systemic. Definitely, we have affordable therapies available for mild and moderate disease. Phototherapy has gotten easier to access with some of the home products out there. It's still not the favorite or it's not the most convenient thing, but it still appears on our algorithm for Mayo, and it's considered to be effective in the guidelines as well. So I think really just putting thoughtful input behind what you do with step therapy can really help.
Okay. Yeah, and I think Dr. Friedman, you with that audience question a minute ago, you kind of walked us through how you kind of step up. I mean, are you still using BSAs though, or is it's more nuanced than that, right?
We do because we have to, because the payers require us to, because again, and we have, and that's another thing to point out, some of these biologics are approved for site-specific psoriasis. So ixekizumab has the approval for genital psoriasis. Secukinumab has the approval for scalp psoriasis, because while small BSA, there still is a tremendous impact on quality of life, let alone these special sites portend a worse prognosis when it comes to comorbid diseases. Phototherapy, we used it for psoriasis when we had to. It really has kind of fallen by the wayside because while there was a recent paper saying it may have an impact on systemic inflammation, it is a huge time suck. Getting people to come in for it, and you did mention home units, which are not as tightly regulated and have their limitations. But I think that, the one thing I'd say when it comes to step through therapy is that it ends up being more costly to cycle through multiple therapies before you get to one that actually works. And so when I'm told to use a subpar biologic before going to one that has a higher level of efficacy, that's wasted time and money, in my opinion.
Perfect. Okay, yeah, I'll turn it over to you to go through a couple more slides, and then I have a couple more questions I want to ask both
Yeah,
of you.
of course.
Yep.
So, I think that there's so much value to guidelines because when you don't have head-to-heads, it really relies. I think, Susan, you said it beautifully that you rely on expert testimony for how you create these algorithms. And so, the International Psoriasis Council is one, National Psoriasis Foundation is another, and this doesn't just go to how you classify disease, what drugs you should be thinking about, what algorithms, but also even for workup. So, the IPC just came out with a statement, really saying that for the IL-23 and 17s, we do not need to be checking tuberculosis tests on patients yearly or even before starting. I can tell you quantiferin gold and T-spots are not cheap. So even that type of stuff is very helpful to limit the overutilization of resources that don't need to be utilized. So I feel like we recognize the value of these for you guys, and we put a lot of work into ensuring that they are up to date and also follow the biology.
Yeah, and we always get asked, how you use guidelines, and that's an interesting answer because we always look at guidelines. If guidelines, though, sequence drugs or help us identify which drug is best for what patient, then I think they're helpful. But in a lot of cases, guidelines are just a listing of drugs, and that's where it gets a little frustrating. So, that's where we, have to look at, key opinion leaders and other sources. And there's my little maybe snarky comment is, sometimes guidelines, if guidelines are a listing of drugs, I would argue that's not a guideline. So that's a challenge on all of us, right? Is to
I
look at the data
agree.
and think, okay.
So no, sometimes guidelines are useless. I'm gonna be honest. Like sometimes we come out and I'm like,
Yeah.
what were you guys doing this whole time? Like this doesn't help anybody. So
Yeah,
I get
yeah.
that.
You wrote down all the drugs that are available. All right. Okay, so we have a few minutes left. Susan, I'm just going to turn it over to you to maybe pivot a little bit and talk a little bit about how we manage patients, in the real world. So, what are the challenges there? And then I'll turn it over to you, Dr. Friedman, to maybe talk about your experience with telemedicine and telehealth and some of the other things that you're doing in this area.
Absolutely.
Sure thing. So we'll touch on a few of these equity and access challenges that are out there for patients who are trying to access care for psoriasis. First is geographic. So you don't get to see Dr. Friedman, as quickly if you live in a rural area. 75% of rural patients must travel outside their home location to get to care. And that compares to only 2% of patients living in a city. And there are only 4.4 dermatologists for every 1,000 patients as well. So that sort of exacerbates that access problem. Then we have socioeconomic factors, such as insurance barriers. Being uninsured can make you 3.4 times more likely to be unable to even access or obtain care. And then high out-of-pocket costs for drugs and other things related to prior authorization to get to those therapies can lead to 21% of patients giving up on treatment altogether. Racial and ethnic barriers can impact your diagnosis, time to diagnosis. Patients with skin of color wait 3 times longer to get to a diagnosis and are 4 times as likely to require a biopsy to confirm that diagnosis. And then Black patients are 70% less likely to receive advanced biologics than white patients. And this has got multiple reasons behind it, including costs, including access. But this causes these patients to have to rely on older, less effective systemic treatments when they are in this category of having darker skin. And lastly, Dr. Friedman touched on this, but our clinical trials they underrepresent certain minority groups, with only 12% of those trials having more than 20% minority participants. And this can lead to those guidelines being less impactful, less effective, as well as training limitations for doctors and mid-levels who are going to treat these patients. So looking a little deeper into this, that lapse between the initial presentation of disease to a dermatologist and the final diagnosis in patients with skin of color is 180 days compared to 60 days in patients who are white. And this comes down to dermatologists being a little bit less likely to confidently diagnose patients who are Black versus white. We've already talked about the number of visits per year can be higher in patients with psoriasis, but also in patients of color. We are not seeing them into the doctor for ambulatory visits as frequently. 1.24 fewer visits per patient per year and over 3 million fewer visits when compared to their white patient cohorts. Just going to try to catch up a little bit. We've got 3 case studies that look at innovative payer solutions. The first, down at Jackson Memorial Hospital in Miami, used a framework to combine the hospital financial assistance mechanisms with the pharmaceutical manufacturer patient assistance programs. They were seeking to provide biologic care at no cost to the patient. And they were successful in doing this and found that 67.4% of patients enrolled were prescribed a biologic. However, they also learned a lot from this retrospective analysis that while 94% of patients had their drug at no cost, other barriers also mattered, such as getting to the appointment, not having transportation, not being able to take time off work or get childcare. So those things are still needing to be dealt with. And you might ask, what about telehealth? So we learned in the COVID pandemic that telehealth is a way for us to get to a physician with just a cell phone or computer. Telehealth visits are associated with a 29% reduction in the odds of no-shows, and they have the greatest impact on patients from socially vulnerable areas. I think it's important to remember that patients do need to have access to something to have their telehealth visit on, so they need to have a computer usually. And just to focus again on oral therapies, these products have advantages that injectables don't have. So they don't need to be refrigerated. They're typically daily therapies versus periodic therapies, so that can change the way patients take these drugs. They travel better, and we're still looking at efficacy with the traditional orals being a little bit lower, but looking forward, of course, I'm going to struggle with this one.
We call it ICO. We all have the same trouble.
ICO, Trokinra has those 90 and 100% PASI scores. So definitely getting into the efficacy zone that we want to be in. I can stop there, Jeff. How do you want to go with our 2 minutes we have remaining?
Patient preference is, I think, another conversation. Payer struggle. I would just say payer struggle with that. That is much more of a provider nuance there. I think that's just probably a fair statement. I'm going to pull up the key takeaways that we had from this, and maybe just ask a couple questions. So one, Dr. Friedman, is, Susan talked a little bit about what payers can do and some solutions there around equity and things like that. What's your input on that? I mean, how do you address patient engagement? Because I'll just say this: I cannot underestimate or understate the importance of patient engagement. We've learned through care management programs, you can't tell somebody what to do. It's much more effective if they buy into it and understand what's going on. So how do you address that? And then maybe I have one more question here. So yeah, we'll pull up. Yeah. And then I'll let the audience read this while we're answering those questions.
Yeah, no, I think that, it has to start really early. And I think Susan did a really nice job highlighting and reiterating some of the key challenges in terms of even making the right diagnosis. Something we didn't talk about is even comfort of the patient and seeing themselves in the practice, in the physician. We published a study showing that patients from different demographics would feel more comfortable if the doctor even looked like them. And so even diversification of the workforce is so hugely important. But at the end of the day, one of the biggest challenges is access to care. And there are a lot of A's to that access. Telemedicine was mentioned. And I think from a payer perspective, though I think this is a little bit bigger in terms of what is even allowed to be considered a visit. During the pandemic, the gloves were off, state of emergency, you can do whatever you want kind of situation, but it's become somewhat restricted. But telemedicine is an incredible way to allow someone who can't physically get to you, whether it be in real time or asynchronous, to actually get the care and recognize the condition appropriately and get on treatment. But again, that has to be allowable, and there has to be a process by which that can happen. And then, of course, access to medications. No doubt, I think being able to access the medications that actually work and not have to go through multiple hoops. And I've had a patient say, "I just give up. I don't even want anymore. I've had to. I've been on the phone for 2 hours." I think that what I would ask of payers is to really provide clear guidance on what you want from the patient, what you want from the practitioner. And also these algorithms and workflows should be a collaborative process in terms of us sharing our experiences in terms of what we are feeling, not even just us as the physicians, but our biologic coordinators, our medical assistants who are doing prior authorizations, even the non-steroidal topicals, which in parallel to the biologics, we've got so many cool new topicals. Like we've got tapinarof and roflumilast and some combos that can be used in such really unique ways that are very effective and very safe. But accessing them are also a challenge. So I think it's about giving clear guidance on what you need from us and how it will be addressed in a timely manner, so we don't destroy the perception that the healthcare system works, so to speak.
Yeah, and just to tag on and summarize here, Jeff, I think the advent of AI and digital tools that can mine data in a whole new way can help us be more efficient, bridge those gaps with prior authorization, make it, almost instantaneous, and also identify patients who might be headed for trouble and get them back on track through helpful case management.
I think that's a great summary, right? So it's communication, it's appropriate drug for the appropriate patient at the right time, and it really is about accessibility and affordability. We all need to work on that, or it's going to go away. So here are the CE instructions. The evaluation code there is AMCP. Just point out again to pharmacists, you have an extra step in this process. Lucky you. You have to download your information to the CPE monitor so it gets tracked. Well, if you have any questions through any of this, though, please contact the folks at Impact Education, and they can help you. So we'll wrap up there. Dr. Friedman, I'm going to take one more minute. I know we're over time here, but there was an audience question, and I think it's important enough to address, and that was around maybe there was an inference that biosimilars are not as effective. So we have a couple of biosimilars now. We have other drugs going off patent, and we just saw a very crowded pipeline. So what is the role of that? Of biosimilars and maybe lower cost, maybe less effective older medications in the grand scheme of things?
So I think, and putting my toxic positivity hat on, I think that a medication is better than no medication, right? So any of these are going to be better than just getting a topical steroid, right? You're treating systemic inflammation. And so if we are, thinking about long-term, and someone put in the question, how long do people need to be on these? Well, technically, this is a lifelong disease. We cannot cure psoriasis. So in thinking about that cumulative financial burden, I totally appreciate it. We have to be mindful that we have to keep the lights on. Being on anything will still be better than nothing at all. And so I think that the biosimilars still have their place. I think the hard part is because, for example, adalimumab has several. How do you know which one to pick? Often our selection is based on what's covered, right? And we don't have studies showing that one is better than the other. There's no need for that because, similar like generics do not have comparative studies because they're they're coming off of the original, the OG medication. So I think that on the one hand, if it's either a biosimilar or bust, I say biosimilar, no question. But I think because of the way these come off patent, they come out, you have a biosimilar for adalimumab, and you want someone to be on an anti-IL-23, there's no comparison there. The anti-IL-23 is going to be more effective. But in being, a realist, would I still rather them be on the biosimilar if they could be on nothing else? 100%, no question.
Yeah, and patient affordability is a component of that.
Correct. Yeah, we have to be realistic too. I am a realist. I would love for everyone to get every medicine we say. The system would fall apart.
That was a great conversation. I really, really enjoyed listening to both of you, and thank you for your time today. We just once again like to take this opportunity to thank Johnson & Johnson and Impact Education for getting this together. It's a very timely subject and topic. And then lastly, just thank everyone for joining us today, and hope you enjoyed it. Hopefully you found it informative. And again, if you have any questions or issues, please reach out via Impact Education.